Nursing 345, Mental Status Assessment. This first slide is a list of this week's objectives. They include understand the use of diagnostic reasoning in clinical judgment, discuss the importance of high-level assessment skills, describe expected physical, psychosocial, cognitive, and behavioral milestones of a patient on the basis of developmental stage, assess the basic characteristics of culture and the steps to cultural competence, define the meaning of common nonverbal modes of communication, and assess the behaviors that are considered in an assessment of a person's mental status. Mental status is a person's emotional and cognitive functioning. Optimal functioning aims towards simultaneous life satisfaction in work, caring relationships, and within the self. Usually, mental status strikes a balance between good and bad days, allowing a person to function socially and occupationally. Mental status structure and function. A mental disorder is significant behavior or psychological pattern associated with the following: distress or a painful symptom, disability, which includes impaired functioning, or significant risk of pain, disability, or death, or loss of freedom. Organic disorders are due to brain disease of known specific organic cause. For example, delirium, dementia, alcohol and drug intoxication, and withdrawal. Psychiatric mental illnesses are organic, have organic etiology, but it has not yet been established. Examples include anxiety disorder or schizophrenia. Mental status assessment documents a dysfunction and determines how that dysfunction affects self-care in everyday life. Defining mental status. Its functioning is inferred through assessment of an individual's behaviors. The behaviors include consciousness, language, mood and affect, orientation, attention, memory, abstract reasoning, thought process, thought content, and perceptions. Developmental competence. This includes infants and children and aging adults. Infants and children, it's difficult to separate and trace development of just one aspect of mental functioning. Aging adults. Older adults contain more potential for losses. Grief and despair surrounding those losses can affect mental status and can result in disability, disorientation, or depression. Chronic diseases such as heart failure, cancer, diabetes, and osteoporosis include fear of loss of life. Components of a mental status examination. You need to keep in mind the four main headings of mental status assessment. They are A, B, C, T. A is for appearance, B is behavior, C, cognition, and T for thought process. Remember, integrating mental status examination into the health history interview is sufficient for most people. You will collect ample data to be able to assess mental health strengths and coping skills and to screen for any dysfunction. It is necessary to perform a full mental status examination when any abnormality in effect or behavior is discovered and in certain situations. When a full mental status examination is necessary, that's when patients whose initial screening suggests there's an anxiety disorder or depression, there's behavioral changes such as memory loss or inappropriate social interaction. A full mental status examination may be necessary if there's brain lesions or trauma, tumor, cerebral vascular accident, or stroke. If there's aphasia, which is impairment of language ability secondary to brain damage, or symptoms of psychiatric mental illness, especially with acute onset. Note these factors from the health history that could affect interpretation of findings. They include known illnesses or health problems such as alcoholism or chronic renal disease, medications with side effects of confusion or depression, educational behavioral level need to be noted. You need to note the factor as a normal baseline and do not expect performance on mental status exam to exceed it. Responses indicating stress in social interactions, sleep habits, drug, and alcohol use also need to be noted. Objective data, which are the main components of the mental status exam, you need to sequence the steps in a hierarchy in which the most basic functions are assessed first. The first steps must be accurately assessed to ensure validity of steps that follow. The steps, again, for you to remember, are appearance, behavior, cognition, and thought process. Specifically, objective data includes posture. Is the person erect and position relaxed? Their body movements. Are they voluntary, deliberate, coordinated, and smooth? Dress. Is it appropriate for setting, season, age, gender, and social group? Grooming and hygiene. Is the person clean and well groomed? Is the hair neat and clean? Use care in interpreting clothing that is disheveled, bizarre, or in poor repair, as well as piercing and tattoos, because these may reflect the person's economic status or deliberate fashion trend, especially among adolescents. Disheveled appearance in previously well-groomed persons are that would be significant. You need to assess level of consciousness. Is the person awake, alert, and aware of stimuli from the environment and within self? And do they respond appropriately and reasonably soon to the stimuli? Facial expression. Is it appropriate to the situation and changes appropriately with the topic? Is there comfortable eye contact unless precluded by cultural norm? Speech. Judge the quality of speech, noting that the person makes sounds effortlessly and shares conversation appropriately. Assess the pace of conversation. Is it moderate and stream is fluent? Articulation. The ability to form words. Are they clear and understandable? Word choice is effortless and appropriate to educational level. Person completes sentences, occasionally pausing to think. Mood and effect. Judge by body language and facial expression, and by asking directly, how do you feel today? How do you usually feel? Mood should be appropriate to the person's place and condition and should change appropriately with topics. And a person should be willing to cooperate. Orientation. Discern orientation through course of interview or ask for it directly using tact. You could say, some people have trouble keeping up with dates while in the hospital. What is today's date? Do they know the time, the day of the week, the date, year, or season? Place. Where does the person live? Can they provide that, their address or phone number, or their present location, or the type of building? Can they name the city and the state? Ask them their own name, so they need to be oriented to person. Ask them who the examiner is, or simply the type of worker. Many hospitalized people normally have trouble with exact date, but are fully oriented on remaining items. Attention span. Check person's ability to concentrate by noting whether he or she completes a thought without wondering. Attention span commonly is impaired in people who are anxious, fatigued, or intoxicated. Recent memory. Assess in context of interview by 24-hour diet recall or by asking time person arrived at the agency. Ask questions you can verify to screen for occasional persons who confabulate or make up answers to fill in gaps of memory loss. You can assess remote memory, and that should be done in the context of the interview. Ask the person verifiable past events. For example, ask them to describe their past health, or their first job, or their birthday and anniversary dates. Ask historical events that are relevant for that person. Remote memory is lost when cortical storage area for that memory is damaged, such as in the case of Alzheimer's disease, dementia, or any disease that damages the cerebral cortex. You can perform the 4 unrelated words test. It's highly sensitive and a valid memory test. It requires more effort than recall of personal or historic events and avoids danger of unverifiable recall. You simply pick 4 words with semantic and phonetic diversity. Ask the person to remember the 4 words. To be sure the person has understood, have him or her repeat the words. Ask for the recall of 4 words at 5, 10, and 30 minutes. Normal response for persons younger than 60 is an accurate 3 or 4 word recall after 5, 10, and 30 minutes. Additional testing for persons with aphasia. Aphasia is the loss of ability to speak or write coherently or to understand speech or writing due to a cerebral vascular accident. Word comprehension. The person can point to articles in the room or articles from pockets, or the nurse would point to articles in the room or articles from pockets and ask the person to name them. Reading. You can ask the person to read available print. Be aware, though, that reading is related to educational level. Writing. You can ask the person to make up and write a sentence. Note coherence, spelling, and parts of speech. Screening for suicidal thoughts. When the person expresses feelings of sadness, hopelessness, despair, or grief, it is important to assess any possible risk of physical harm to himself or herself. Begin with more general questions. If you hear affirmative answers, continue with more specific probing questions. Have you ever felt so blue you thought of hurting yourself, or do you feel like hurting yourself now? You can ask, do you have a plan to hurt yourself? How would you do it? What would happen if you were dead? How would other people react if you were dead? It is very difficult sometimes to question people about possible suicide wishes for fear of invading privacy. However, risk is far greater when you skip these questions. If you have the slightest clue that they are appropriate, you may be the only health professional to pick up clues of suicide risk. For people who are ambivalent, you can buy time so the person can be helped to find an alternative remedy. Share any concerns you have about a person's suicide ideation with a mental health professional. There is also the mental status examination. It's the mini mental state exam. It concentrates on cognitive functioning, not on mood or thought processes. It's a standard set of 11 questions and requires only 5 to 10 minutes to administer. It's useful for both initial and serial measurement, so worsening or improvement of cognition over time and with treatment can be assessed. It's a good screening tool to detect dementia and delirium and to differentiate from psychiatric mental illnesses. The normal mental status average is 27. Scores between 24 and 30 indicate no cognitive impairment.